Hey everyone, my name is Donald Solomon. I'm one of the residents at the Huron-Valley Sinai Hospital of the DMC. Today I'm going to be talking about the QI project that we did some research on, titled the Modified CIWA Protocol. My team members include Karam Dev Grewal, David Alderi, and Dr. Amajid Sethi, our ICU attending. So a little background information. The CIWA protocol, also known as the Clinical Institute Withdrawal Assessment Alcohol Revised Protocol, is essentially a measurement tool that we use for patients admitted with alcohol use disorder to kind of objectively identify the severity of alcohol withdrawal based on assessing certain clinical symptoms such as nausea, vomiting, tremors, sweats, anxiety, agitation, both auditory and visual hallucinations. Essentially, what the CIWA protocol does is it allocates a point scoring system based on each symptom, and then benzodiazepines are administered to treat those psychomotor symptoms of the alcohol withdrawal. As we kind of know, benzodiazepines are our first line in treating alcohol withdrawal. However, there is relative contraindications where these medications may not be beneficial, and so barbiturates can alternatively be used to treat the withdrawals. So this is kind of what this QI project is based on, comparing the effectiveness and the efficacy of benzodiazepine versus phenobarb in alcohol withdrawal treatment. Um, the objective, as clearly stated here, is to collect data on patients admitted with alcohol withdrawal and compare phenobarb versus benzodiazepine regimens to treat alcohol withdrawals. So essentially the method that we used was we collected information about these patients using the charting EMR at our hospital. Patients that were admitted from July 23 to December 23 were included in the study, on the teaching services and also those admitted to the ICU. So patients were placed into four categories, one being treatment with phenobarb, one being treatment with lorazepam, one being treatment with phenobarb and lorazepam, and the fourth being the standard CIWA order set using lorazepam and the necessity of using a Precedex drip to treat agitation. The outcomes included the length of stay, the ICU length of stay, the severity of the withdrawal of the symptoms, which include seizures, delirium tremors, need for intubation, and so forth. And we kind of compared the primary outcomes against these four patient populations. So, what we found in the results of our retrospective analysis was that a total of 60 patients were admitted to Huron-Valley Sinai Hospital between the month of July to December 2023, for alcohol withdrawal. 60 of these 60 patients, 26 were loaded with phenobarb at the discretion of the ED physician, and they were placed on a regimen that included a dosing of phenobarb 3 times daily. Of these 60 patients, 34 patients were placed on the CIWA protocol, which included the administration of lorazepam. 28 of these 34 got oral lorazepam, and 6 of the 34 patients got IV lorazepam. Of the 26 patients that received phenobarb, 5 had to be admitted to the ICU, averaging a length of stay of 3.4 days and a total stay of 4 days entirely. There were no patients in the phenobarbital group that required intubation in the ICU, and the loading doses for phenobarb relatively ranged 130 milligrams in 3 of the 26 patients, whereas 23 patients received a loading dose of 260 milligrams. And this was kind of based on the discretion again as the admitting attending in the ED. Unfortunately, 8 patients that were placed on the phenobarbital regimen had to be administered lorazepam simultaneously for breakthrough tremors and agitation. 34 patients received lorazepam in the ED, and they were also put on the standard CIWA protocol that we know, 28 of which received oral lorazepam, and 6 of the 34 patients receiving IV lorazepam. Of the 34 patients that were placed on the CIWA protocol, 6 of them had to be admitted to the ICU, and one of the 6 patients essentially had to be intubated due to the severity of their alcohol withdrawal. The average length of stay for the ICU was 4.6 days, and the total length of stay for this lorazepam group was approximately 3.5 days. Of note, the 26 patients in the phenobarbital arm, 3 required Precedex to aid with agitation, and in the lorazepam group, 4 of these patients required a Precedex drip. I think it's worthwhile to mention that Precedex kind of masks the psychomotor symptoms of agitation, but they sort of required this because of the severity of the alcohol withdrawal at this time. And then what we found in conclusion was that the regimen of phenobarbital and the regimen of the CIWA protocol using lorazepam, the superiority kind of is still undetermined and unclear. It's kind of based on the physician's discretion. What we also noticed is that physicians were more likely to use the CIWA protocol because it's a tried and tested method that everyone is familiar with and uses. And, people tend to not want to do anything new, especially in patients that appear a little bit more ill or a little bit more toxic than, usual. The prolonged length of stay in the hospital based on the CIWA protocol was largely subjective when it comes to individuals' assessment on severity. And this kind of means, healthcare providers may have been administering too much benzodiazepines because the psychomotor agitation was maybe triggering on the CIWA, maybe someone had a meal, maybe their heart rate went a little high, and this caused them to, score a little high on the CIWA protocol and be administered benzodiazepine inappropriately. So that is one of the drawbacks. And then another thing that we found from this study was that physicians are a little bit more reluctant to schedule benzodiazepines. In a study conducted by Sates et al., symptom-triggered approach to therapy, individual treatment, and decreases both treatment duration and amount of benzodiazepines used. So despite the CIWA lorazepam treatment having a comparatively prolonged length of stay, symptom-triggered benzodiazepine use is associated with a decrease in both the duration and the quantity of the medication used. And although phenobarbital is an older agent that has fallen out of favor, it has its clinical use, especially recently, due to its established superiority when it comes to treating patients at greater risk of dangerous complications of withdrawals. Again, it's still unclear whether phenobarbital front loading reduces the risk of withdrawal when compared to the CIWA-based lorazepam. So there is still need for further research, assessment on whether which one is superior and which one works best. So I hope this presentation was useful and insightful, and thank you guys.